earlier this summer on this topic. So here's a list of references from that article. So I'll be quoting things from that. And I don't want to plagiarize any of the sources. I really was motivated to write that with all of the events that happened this year and the social unrest, but I've been thinking about this issue for quite a while. I want to talk about ethics and disparities in healthcare and clinical skills that can help us deal with both of those. So we'll take kind of a meandering, circuitous route, but we will try to connect those all together. There's a textbook that was written in 1979 by these two authors. I think it's in the 13th edition, on principles of biomedical ethics. And these are the 4 pillars, they're sometimes called, or principles that are very common to see anytime medical ethics gets discussed. So some of them we're probably more familiar with than others, but autonomy is the idea that self-determination is an important part of providing medical care, so allowing the patients to make decisions, informed decisions about their health care. And so informed consent is part of that. The idea of benevolence, that a primary goal is to do good, and then connected with that, non-maleficence, which is doing no harm. Slightly different take on that. The final one is one that I've always found a little challenging to think about and understand. But distributive justice is the idea that we should be fair in how we distribute resources, and in this case, medical care. So making decisions based not just on an individual case, but as a group or society, making decisions considering the needs of everybody and distributing those resources fairly. I think it helps to take a step back and think about what ethics are, or what the definition of ethics is. And ethics are moral principles that govern a person's behavior or the conducting of an activity. And we get our sense of what is right and wrong, or our morality, from a few places commonly. It's our family tradition very often, or family culture or belief system. Very often religion, a specific religious belief system plays into that. And it certainly affects our politics, our view of the political situation, and vice versa, right? So our political viewpoint could impact our sense of right and wrong. I think fundamentally, most people understand ethics to be what's the right thing to do in a specific situation. In the case of what we do, what is the right thing to do for our O&P patients? That can become a complicated question when the 4 different principles or pillars put us in a situation where there's conflicting demands, or they kind of pull us different directions. So an ethical dilemma is when there isn't a simple solution to the scenario we're dealing with, or the case we're dealing with, because different priorities are pulling us different ways. So in terms of distributive justice, one of the issues is, what does it mean to be fair? And that starts in elementary school and on the playground, or maybe even sooner than that, preschool, for all of us humans. And then it continues to get more complicated as we deal with bigger and bigger issues in life. And medical care is certainly a really big issue. But in my mind, it doesn't resolve the issue to say that to address this ethical pillar, we need to be fair, because the definitions of fairness can vary quite a bit. So distribution of resources based on what? Should it be based on need? The individuals with the greatest need get the most medical care. Should it be based on effort of some sort? So maybe the effort individuals are putting into their own healthcare. Should it have to do with contribution, especially in a system in the US, and then even more so in other countries where the tax system is what funds much of the healthcare? Should it be based on how much contribution each person makes? Or is there some other type of merit that should make people earn their healthcare and make it therefore just or fair in how it's distributed? One example to show how we've decided to address this as a society is Medicare, which is not available to everybody, but it's available to everybody over 65 and some other conditions. So you can view that as fair, even though not everybody benefits in the same way from that system. One of the issues that comes up, I'm sure you've seen this graphic that's on the right side of the slide, is what the goal should be, or what fairness and equality looks like. So in the one image, equality means everyone has the same opportunity or given the same resources, and equity is a little different of a standard, actually quite a bit different of a standard, where resources are distributed to ensure or at least help towards a common outcome for everybody. So when we talk about these issues, I think immediately raises some really big political issues. It's hard to disconnect those from what's going on immediately around us and in politics and on social media. So I realize that there's some danger in pursuing this discussion. There's some high risk connected with talking about these topics. We've all heard the standard advice to not discuss religion or politics at work. And if ethics are really about morality, and one of the major sources for our sense of morality are things like religion and politics, it makes it hard to discuss those topics, especially at a meeting like this, or as colleagues in a work setting, professional setting, without violating that rule. On the other hand, are we really supposed to avoid talking about some of the most important aspects of the care we provide and the needs of our patients? Seems like that's not a real wise way to proceed. It certainly is advisable to avoid conflict with our patients, coworkers, referral sources. But at some point we have to decide, even if it's an individual practice or an owner of a practice, how we're going to use our resources that we make available to individuals. So I think when we have these discussions, we have to decide what the goal is. And if the goal is agreement, then we probably are setting ourselves up for disappointment and conflict, because it's probably unlikely that one presentation or one conversation is going to get everyone on the same page. If that was possible, that probably would have happened a while ago, but it doesn't seem like we're any closer to that as a society. Another goal that's commonly given as an advisable goal is tolerance. And just speaking from my own experience, I feel like I've seen more examples where tolerance is used as a weapon and not as a motivation for resolving things or coming together onto the same page. But I think in spite of those dangers and challenges, this is an important topic. I think at some level we all are wrestling with this, and it's worth talking about as professionals. How do we address the ethical responsibilities we have and our professional responsibilities in view of that fourth pillar of biomedical ethics? For myself, I'd like to define, for this presentation and any discussion I'm in, I'd like to define success as, first of all, an increased awareness. So one of the things over the last year or two that I've done is read a lot more, talked to different people who don't agree with me or have the same views. Just getting an awareness of what people actually believe and why, without primarily hearing that to make my own response or convince them. So just raising awareness is a good goal. That could lead to some better understanding. Very often we portray someone else's position in a way that's not really fair to them or accurate, because we just genuinely don't understand or maybe don't want to understand what their viewpoint is. And then finally, I think it's actually possible to respect individuals who don't have the same view, even if it's on a really serious issue and it's not something we take lightly, that we can definitely show respect to each other, but actually genuinely have a respect that intelligent, well-meaning people who want to do good in the world don't always see these issues the same. All right, so that's kind of the introduction on ethics. And let's talk a little bit about disparities and connect those two things. So the first step, I think, is to recognize or get at least a little more awareness and understanding of the extent of disparity. So how do you measure disparity? And there's obviously a lot of ways. One good way is to demonstrate or talk about life expectancy. So the goal of all healthcare ultimately is the quality of life and the length of life. And what we do as process orthotists certainly affects both of those. If you were to take a drive along the south side of Minneapolis, St. Paul on I-94, driving just 3 miles would take you past neighborhoods where the life expectancy varies by 13 years. In Kansas City, the same distance, you'd have a 14-year difference in life expectancy. So just living in those neighborhoods can either lengthen or shorten your life, or at least statistically living in those neighborhoods, you're part of a population that lives more than a dozen years longer or shorter. In New Orleans, it's even more extreme, where a distance of just a few miles is a quarter of a century difference, 25-year difference. So that's the difference between dying at 50 years old or 75. One would be considered fairly premature by most of us, and the other is probably considered a full and active life. This information is available on the website of the Robert Wood Johnson Foundation. It's the largest organization of its type that focuses exclusively on healthcare and healthcare policy. So they have a lot of information that's available. And I think understanding a little more about disparities can help us understand the patients that we see, because I think most of us can be thinking right now about the vast disparity we see in the resources patients have available to them that we see, and the condition, their health condition. So another part of what the Robert Wood Johnson Foundation does is this county health rankings website. So if you go to that website and enter your zip code, as I've done, you can actually see all sorts of statistics on many, many different aspects of healthcare and other aspects of individuals' lives. So they use a model that we'll talk about a little later, but you can look at health behaviors, for instance, rates of smoking and obesity, physical activity or excessive drinking, and then access to clinical care. And just spending a little time helps you realize, just based on the county I live in, where does that compare to the rest of the US or regions close to me? That can give a very different perspective than what we may see day to day, just in the circles that we live and work in. So what that data shows in a compelling and graphic way is the vast disparities that exist. So however you want to define them, or however we think they should be solved, there's clearly really big differences in how people are living and the effect that that has on their health and healthcare. A lot of the issues that we deal with, or that our patients are dealing with, are called lifestyle diseases. So there are choices they make as part of their lifestyle, or we make, and that contributes to disease conditions. So it's very common to refer, for instance, to diabetes and heart disease as, at least in part, lifestyle diseases. So you'll see some conflicting opinions about whether that's an accurate description of those conditions. But the science is pretty clear that there are behaviors and choices we make that have a significant impact on those conditions. So at least part of our health and our patients' health is in direct response to, or a direct consequence of, how they choose to live. There are a lot of other issues that contribute to someone's ability to function and their quality of life, and ultimately the length of their life, that we might say are even more within their control. So there may be genetic predispositions to some of those diseases, something like hygiene, being on time, the family dynamics in our immediate family, and then employment choices. We might say, well, those are more in our direct control than even some of those disease factors are. All of us recognize as well that a lot of those factors determine how well somebody does with the devices we provide and the care we provide to them. So I used to routinely tell patients, when I saw them after an amputation, they're obviously very concerned with how they'll function. And most people, when they survey individuals, believe that amputation is one of the disabilities that they fear the most. And I would have this conversation with patients saying, really, it's your other health conditions probably that will cause a bigger problem. There were also other choices in their life or realities about their life that were going to cause more of a problem for them, even in terms of functioning and walking, than just the fact that they had an amputation. So again, getting to understand some of those a little deeper might help us provide care in a little better way. So this model that I referred to earlier from the Robert Wood Johnson Foundation, and those are the stats on the website, are divided up based on these categories, but they basically evaluate health outcomes, which they define ultimately as length of life and quality of life, are determined by a number of factors. So on the right side there, the darker blue, you can see the 4 different categories of factors: health behaviors, clinical care, social and economic factors, and physical environment. And they're weighting these based on what they contribute to those 2 outcomes, quality of life and length of life. So I think most of us would say tobacco use, diet and exercise, alcohol and drug use, sexual activity. Those are clearly health behaviors that individuals bear some, if not all, responsibility for. So those are choices we make. If you look at some of the other categories on the other end of the spectrum, there are factors that really none of us can control. So air and water quality in our neighborhoods, for instance, or housing and transit are a little more difficult to control. So for instance, if a patient relies on public transportation, they're going to rely on the bus schedule and the bus route that they can't really easily change. So you could think about somebody changing their physical environment by purchasing a house in another neighborhood, right? That's a fairly simple solution. Well, it's simple in concept, but it actually involves a very complex set of decisions over a long period of time, right? I'd have to be in a situation where I was making enough money and saving it and making a lot of other decisions that put me in a situation to be able to afford and make that move to change my physical environment. Social and economic factors, none of us can really control the economy. We may have a very small role in our immediate economical experience, but there are really big factors that we can't control that affect health outcomes. So I think this is a helpful chart just to recognize health behaviors are personal responsibility, but the outcome in terms of overall health, longevity and quality of life is a result of a lot of other factors. Those other factors are often called the social determinants of health. So this is where we could start to tread on a little bit of thin ice here, but I'm going to ask you to think about this statement on the slide without focusing on a particular group, your own or a different group, and just see if that statement, if you think it's accurate or makes sense. An unequal distribution of the resources that support healthy behaviors can create systems of disadvantage that contribute to disparity in outcome. In other words, decisions we make about our own care, our own health care and lifestyle definitely contribute to the outcome and the disparity in outcome. But in addition to that, and perhaps to a greater extent, the resources that support making those decisions in a good way are not equal across every population or group or area. So if you work backwards through a series of factors here, most of us have health insurance. We can cover medical costs because we have health insurance. And we have that health insurance because we have a stable, well-paying job relative to a lot of other options. And we have that job to a significant extent because of the education and background that we've had, whatever role we're playing in O&P. And where the type of education we get, the quality, the length, and the depth of it is determined to a large extent by where we live and our housing situation. So housing is very closely related to education, which is closely related to income potential, and in a real sense, opportunities for long-term employment, stable, high-paying employment, and that's where most of us get our healthcare from. And the quality of healthcare is determined by that. So there's a lot of different factors that go into this that the patient may or may not, or we may or may not have direct control over. And it's easy to look at that equation and say, well, there's a couple simple things somebody can change. But when we say that about a complex issue, it's usually a gross oversimplification. So there's a lot of complex interrelationships. When patients come into our office, by the time they've had an amputation or some other condition, thinking especially about adult or geriatric patients, that clock of social determinants of health has started ticking a long time ago. and arguably even before they were born. So the location of their birth and the parents they chose or couldn't choose have a big effect on factors that we'll see 50, 60, 70 years down the road in their O&P health. This connection between housing and healthcare became more real to me when my wife, about a decade ago, started working in affordable housing in our area. So she started working for Habitat for Humanity, and then is now the executive director of an organization called Homestart. Neither of these organizations give houses away to people. Some people are not clear on, for instance, Habitat, but individuals purchase a house and they're given support and education and resources to help with that, but it's ultimately their responsibility. But learning just through what she was learning and doing helped me realize the connection between housing, which is not something I would have connected with education and health. But what they found is that when housing is stable and safe, every other metric in somebody's life, including their healthcare, tends to improve. Any other outcome you want to measure. So they're able to stay in a particular neighborhood, in a school system where the children have consistent education, even if it's not as high quality as another neighborhood, just not having to pick up and move because the housing is stable makes a huge difference. If somebody doesn't have that, then that obviously is going to affect a lot of things, including their health in their life. I find it's always helpful to think in terms of pediatric cases because we can have a discussion about how much adults are responsible for, but we'd all agree that there's, of all these factors, or thinking about all these factors, the infants and young children have almost no control at all. Even the choices that they appear to be making are very highly defined and constrained by their parents. So if you imagine a child growing up in a disadvantaged neighborhood where they don't have stable and safe housing, and they may not have access to a healthy food source. There may be fast food all over, but there's not a grocery store within walking or even easy driving distance. That also limits their education opportunities. So the school system may be significantly lower in quality. And they, from the very beginning of their education, and especially in very early formative years, are not getting the education background or the preparation for later stages of higher education. That then leaves them in a situation where there's not as many job opportunities available to them as if they had stable housing and a better education opportunity. And therefore, just like us, where our healthcare costs are dependent on health insurance, theirs are as well, except they don't have the same level of health insurance or have it at all. So they're either left with nothing or a much lower level of resources available to them. So again, we wouldn't hold an infant responsible for that, and yet we see them in our office and somehow have to deal with this issue of how do we distribute resources to what's now a fairly helpless infant. One of the things that comes up a lot in discussions like this is the idea of making decisions and taking advantage of opportunity. And in 7th grade, our social studies teacher, I remember vividly being taught the decision-making process. And it was very similar to what this graphic is: identifying a problem, generating options. You analyze those options in light of your values and what's important to you and what you prioritize, and then you select the best option. And we really emphasize very often, especially when we've been raised that way ourselves, we really emphasize the idea of control and choices. And among all the options, some good, some bad, some better, we need to learn how to take advantage of the opportunities we have and make better choices. I think talking about opportunities and advantage or disadvantage, and the P word, privilege, which is kind of a trigger word, but that is helpful in understanding when this cycle has broken down. So if somebody really doesn't have options, they may identify the same problem in their life or healthcare management that you or I do, but they simply don't have the options. If you take them as they present today in our office and not ask the question in the immediate encounter about how they got there, they may just not have the options that the rest of us do. So it's putting this a cycle up as the standard breaks down if any one of those breaks down, particularly the ability to even have options. Over time, not having any options, we don't develop that skill of identifying a problem, analyzing options, and then selecting the best. It's very easy to fall into a pattern of not even considering things a problem that really are. So we may not recognize them or know they are, or we may just have learned to ignore them. So why should I focus on a problem when I don't have any solutions available to deal with that, or any options? I think that's a helpful part of understanding as well the challenges that many of our patients are facing. Dr. Michael Marmot is the chair of the World Health Organization's Committee on, or Commission on Social Determinants of Health, and he's written this book, The Health Gap. There's some interesting videos on YouTube if you're interested in seeing his perspective. But he addresses that issue that we tend to think of disparities in healthcare as poor versus the rest of us. And the reality is that there is a different level of quality of life and length of life all along the social and economic spectrum. So for instance, in England, where he's based, an individual at the middle of that gradient has a lifespan or expectancy that's 7 years shorter than someone at the top. So it's not a matter of being on a completely different spectrum, it's that we're really on the same spectrum as our patients, either the ones who have the most resources or the ones who have the least. And there's an issue of the more resources available and opportunity available that we can take advantage of, the better health outcomes become. So recognizing that that's an issue for everyone, including us, and we may have good insurance and a stable job, there are still factors, determinants that are related to things other than the choices we make. I think is one way of putting ourselves in the same position as our patients and not looking at them as in some sort of different category. So back to the issue of distributive justice. How do we distribute the resources we have, the time, the energy? Every practice that I've been a part of has provided services for free, for instance. That's one way I think of attempting to address disparities. But I think it's worthwhile talking about practices or skills that we could develop to help us navigate and help our patients navigate these situations. All right, so we talked about ethics, talks about disparities, and now let's talk about clinical skills. I know when I think about these issues, when I've thought very practically in clinical practice, on day-to-day with a patient in front of me or in the exam room, and when I think just about the concepts and ideas, it feels sometimes like I'm on a seesaw. We're pulled different directions by the different obligations we have and responsibilities. We may be pulled one way by our sympathy and our feelings for a situation, another way by our economic impulses, and what really are our ethical obligations to every patient we see, especially those that are in need. There's our personal values and morals and political views that come into play. So I think most of us are able to go through our day-to-day work and not make, not in an overt way, treat people poorly who have different views on those, but it certainly comes into play when we make decisions about how to respond to the need we see. And ultimately, we recognize day to day that there's this disparity. How do we make a decision to distribute those resources? So bringing it back to this slide, I find the issues of, for instance, hygiene, tardiness, family dynamics, and employment to be almost daily realities when you're working with a large population of patients. So obviously the major disease processes that affect patients we see are always a reality. But I think we tend to avoid difficult discussions about some of these things. So we just have a way, formally or informally, that we deal with issues like hygiene. So we have the patient come in as the last appointment of the day, or we have special arrangements in how we care for them or where we care for them. We may have policies about tardiness and the consequences of missing appointments and those sorts of things, but we tend to not direct these situations, address them directly. And I think we miss an opportunity to deal with them more effectively and ultimately help the patient navigate them. because most of us don't have the skills and it's not been considered part of our responsibility. So according to ABC, our responsibility is to use all reasonable efforts to meet the patient's prosthetic, orthotic, and pedorthic needs. And we assume the responsibility for performing the tasks associated with the practice analysis, accreditation standards, and the scope of practice. So is it within our scope of practice to talk to somebody about hygiene? What about their tardiness? So I'd argue that just like we can't guarantee a perfectly fitting orthosis or prosthesis, that's not what ABC says is our professional obligation. We need to make every reasonable effort to. We still make the best effort we can to provide that, recognizing there are other factors that we can't control. I think we can address some of these other issues as part of our reasonable efforts and our professional responsibility without taking on the responsibility for the patient's ultimate situation, their health outcomes in totality. So I want to talk about a few skills that I think can help us do that. There's 4 skills that are part of the motivational interviewing process. Some of you may have heard of that at Academy meeting or elsewhere. I want to talk about just 2 of them. Whatever skills we use in having conversations with patients, especially about tough topics, the goal is not to manipulate and not to convince them or not to just get what we want out of that, but to hear what their perspective is. And I think when we do that, we might realize in a much deeper way and more helpful way what challenges the patients are actually dealing with. So I'm going to talk about open-ended questions and affirmations. So open questions are those that invite other people to tell their story and in their own words and not leading them a specific direction. So closed-ended questions can be answered usually with a yes or no or just a fact. So how long do you wear your prosthesis? That's a time we're looking for, right? A number of hours, a number of minutes. A way of asking that would get better information and would let the patient determine how they answer is, tell me about your wear pattern. So that's not a question, but we recognize that as falling into that open-ended category. So now the patient may actually give us a lot more information that's useful. We learn more about what is really happening instead of just a number of hours. Usually avoiding the why question because people can perceive that as threatening, but focusing on what or how can get us a lot better information about what they're really experiencing. So if somebody isn't donning their prosthesis correctly, that's a health behavior that we'd like to see change. It's within their control, or at least we believe it is. It can be very frustrating for us, right? We make something that fits and functions appropriately, and they won't even wear the right number of socks with it. And they may come in and say, this leg is just too hard to use. So I don't know what goes through your mind when you hear that, but I immediately think, so you're saying that I made it difficult for you to use your prosthesis, or that's at least one interpretation. Asking them something as simple as, well, what's difficult about it? Instead of jumping to a solution, say, no, it's not difficult, you're not attaching the strap right. Well, it may not be the strap that they have a problem with, right? It may be something else, but just giving them a chance to explain that more, we may realize that the problem is actually they can't get to their sink to clean things, and they can't get to an area where they can safely put it on, or factors like that have to do with their environment and their living situation. I don't know about you, but I have a hard time picturing the situations that people live in. I tend to assume they're living in a similar arrangement to me, and that's not true for many of our patients. Somebody has an order for an AFO because they have a plantar fasciitis contracture, and they say, well, I don't really think sitting around is a problem. Well, we could assume that they're lazy, that they just don't want to put out the effort, but there may be deeper issues going on that if we were just to ask, well, what is it that's keeping you from getting up and walking around more? Can you describe what happens when you get up and walk? And we might find out that there's specific things that are a barrier to them using their orthosis that we had not considered. Somebody who's chronically late. Getting to this office is a pain in the butt. I used to work in an office that had one of the most complicated locations in the city, and just trying to give people directions was frustrating. So is that what they mean? Or do they mean that I can't get the ride service to come at the time they say they're going to? So it ends up being a full day just to come in here for a half-hour appointment. And I have to sit and wait for 3 hours on either end of that. That may be what they mean. Or it may mean I can't drive anymore because my doctor just told me that I can't have a license and I can't find a friend or relative to help me because they all work. Those are all very different scenarios that have to be addressed differently. If we don't know what specifically they mean by that particular pain or challenge, then we can't help them deal with that. Somebody not cleaning their orthosis, it's just hard to get this thing clean. Again, there's many ways that something can be difficult to clean, right? It may be that they don't have hot water or they don't have running water in their apartment currently. So knowing what they're facing can help us deal with that. And my point is that I think that's part of providing O&P care. It's not our job just to provide something that fits and functions, and then it's up to them to make everything else work. I think these types of issues are part of our care, and we're all dealing with them every day anyway. So maybe having some different skills would help us deal with them. The second skill I want to talk about is affirmations. So recognizing client strengths and acknowledging behaviors that lead in the direction of positive change. This is really difficult, at least for me, probably for you, when we're observing behaviors that are not healthy behaviors or decisions that are not good decisions. And our tendency is to want to correct and give education, which is part of our clinical responsibility and ethical responsibility. But what we really want to do as part of that exchange is help them get confidence in their own ability to make good decisions. It just really doesn't work with most adults to punish, either verbally or in some other way. Criticism tends to be pretty ineffective. And sometimes, in fact, it can work against what we're trying because it just strengthens their resolve to not be told what to do and to continue with whatever behavior they're engaging in. A key point about affirmations is they have to be true. So you can't just make things up that aren't true at all, that they know aren't true. It doesn't really help. But for instance, if somebody is coming in late to the office, the first thing I want to do is correct them about their time management and schedule and give them advice about how to manage that better. But a way to affirm when they're in front of you is to affirm the fact that they actually made the effort to come in. A lot of our patients don't, right? We lose them completely to follow-up. They have problems, we never hear from them again. That's not ultimately the outcome that we're looking for. So saying something like, I'm really impressed that you made the effort to come in today. And then that may lead into a discussion about, let's talk about when you arrive and the best way that I can provide care to you and the other patients I see. The inference there, or you can actually say this, is that it's great to see that this is important to you. They didn't necessarily come in and say, I know I'm late, but at least I've made the effort because it's important to me. But just the fact that they're there, we can infer from that sort of logically that it is important to them. And that's not important to all of our patients. Some of them don't come in and don't let us know if they have problems. So somebody comes in, and a mother with multiple children, and says, I try to put her braces on every day, but I have 3 other kids to take care of. So we may perceive this as bad parenting, not making it a priority, not caring enough about your child who has a disability, but they may be dealing with really complicated issues, as anyone with kids knows. Complicated on top of that is the fact that at least one of them has a significant disability, and it can be very, very difficult for them to navigate that. So just affirming, it must be really draining for you to take care of 4 kids, and it looks like you're working really hard to balance all of their needs. That's probably not what they're expecting. They're expecting to be scolded and corrected and told they should take better care of things. And there may be a time to gently work that in, some sort of corrective advice, but starting with an affirmation is a great way to get the patient on our side. Somebody comes in, and this is a really tough one. I like including this one. It's not directly the topic today, but somebody comes in and says, I'm tired of all adjustments on my leg. I wonder if you even know what you're doing. So the first thing that creates in me is a defensiveness. Like, yeah, I know what I'm doing. Maybe if you wore it right and you wore the right number of socks, it would work better. The problem's not me, it's you, or some more professional version of that. But just letting the patient know, I really appreciate that you're telling me exactly what you're thinking, because I think we can work this out if we're honest with each other. So I really appreciate you being truthful with me about what you're feeling. That might actually work for us in a lot of our personal relationships and conflicts, but usually in a situation like this, people aren't expecting an affirmation. So it can be really powerful if done genuinely and with the right intent and truthfully. It can be a really powerful way of helping them navigate those issues. And then it opens the door up. They're not likely to talk to us about more of their issues and barriers if they've been shut down on the first thing they say. All right, so we do have a responsibility to try to get our patients to change their behavior. There's no question about that. It's a part of our professional responsibility, part of our ethical obligation. If they're not wearing their prosthesis right or not cleaning it right or whatever the issue is, we have a responsibility to communicate. But just finding out where their motivation level is and what their involvement level is it gives us an idea of where to start with that. So people will usually express something in the area of desire, ability, reasons, or needs. So the convenient acronym is DARN. So they may not want to. Maybe they should change their behavior to a more appropriate wear pattern or whatever the issue is, but they don't have the desire. They may have the desire, but really don't have the ability to. So I really wish I could clean this appropriately, but I don't have a wash machine. Well, that's a very different discussion. So in eliciting change talk, what that refers to is listening for and encouraging the talk, the way that the patient makes statements about desires, ability, reasons, or need to change. So they may say, I know I really should change and walk more on this prosthesis. They may not say need to change, but they may say, I really know I should walk more. I'd really like to be around to play with my grandkids. They're giving a reason that's much more powerful to them than all of the other reasons I could think of that are reasons to use your prosthesis the way you should. So we're looking for statements they make that indicate where on that spectrum they are. If they don't want to change or do want to change, and we want to encourage the ones that are headed the right direction. Another thought about, as we're kind of wrapping up, another thought about change is the idea of readiness. And readiness is a combination of importance and confidence. So change occurs when it's important enough and I believe I can achieve it. If one of those two things isn't true, then we don't change. So change happens when the patient's ready to change, not when we're ready for them to change. And that's true of you and I in the same way. It's a universal principle. So assessing whether the issue, if they're not changing and making better health decisions, is the issue that they don't realize the importance, or is it that they do, but they just don't believe they can actually make the change? Those are two very different discussions. So here's a technique. It's my favorite technique in this whole area. I feel like it's kind of the judo of communication with individuals who need to change. But you can say to somebody, you really need to clean your prosthesis and your socks so that you don't have skin breakdown. And is that important to you? And if so, how important is that for you to keep your prosthesis clean? So they know what you want them to say, right? They know you want them to say 10. This is the most important thing in my life. And it's helpful to remember that O&P care to us is the most important thing in their life, but it may not be to them. So they'll pick a number in the middle often. So well, it's about a 5. And that's convenient to say it's 5 out of 10, right in the middle. And our tendency is to say it should be a 6, 7, 8, 9, or 10. Why isn't it a 10? And they say in response to that, well, because, and whatever they say next is a reason for them not to change, not to wear their prosthesis or wear it correctly. We're asking them to tell us why they're not doing it correctly or why they make the wrong decision. If instead we say, why didn't you say 3? So you said 5 on the importance scale, but you could have said 0, 1, 2, 3, or 4. Why didn't you? And the person says, well, I know that the doctor says it's good for my heart if I use my prosthesis and get up and walk. And I know you've told me it's better for my skin if I clean my socks and my liner. And they start listing reasons that they are using to convince themselves for making the change that we're encouraging. And there's nobody more convincing to any of us than ourselves. So instead of having them hear themselves arguing against a change, they hear themselves arguing for it, which is a really powerful technique. So say they told you exactly what you want to hear, and truthfully, it's an importance level of 10. And then we can ask the same question about confidence. So I know you really want to keep your prosthesis clean, or you want to show up on time, or you want to put your child's helmet on. But how confident are you that you can make that happen every day? And it's the same process. They may say, well, I think a 5. Well, why didn't you say 2 or 3? And now everything they say is going to be building blocks towards showing them, well, you really probably do have the resources to take a step in the right direction. So, well, maybe I could have my husband help in the evenings, making sure the helmet's clean and put on before the child goes to bed. Or maybe I could ask my wife to help. I don't really want to ask her because she already does so much, but really I think I need her help cleaning my socks and liner. So now they're starting to give solutions to their own problem and arguing for making the right change. So there are a lot of resources available on the Academy Learning Center, Online Learning Center. There's at least one Academy Today issue from the last year or two on motivational interviewing. There's some O&P Edge articles. There's an upcoming Academy Today article where Rebecca Herman, who's a CPO at Shriners Hospital in St. Louis, has written a really insightful article on missed appointments, which, as we all know, is extremely frustrating. And a way of thinking of that, and even some strategies for dealing with it that take into account that there are a lot of factors that go into somebody being available for appointments and being able to keep them. It's not just a matter of discipline or how important it is to them. So feel free to look at those resources. Obviously, email me. Be happy to talk about this at any time. But it's kind of been like I warned, a meandering sort of path through these topics, from these big ideas of ethics and disparities in healthcare and big problems to what can we do clinically day to day that could take that into account and maybe even be a positive influence in the right direction. I don't think that there's any simple solutions. Sometimes the fact that there aren't keeps us from making simple choices that we could make that would make our care better and the outcomes better for our patients. So it's helpful for me, and it may be for you, to not think about fixing the whole system, which is way outside any of our control, and think instead about what are some ways that we can build confidence and readiness and willingness in our patients to make healthy choices. And that takes a different set of skills than many of us sort of grew up in the field learning. So helping them navigate those challenges ultimately is going to help them with better outcomes. So our goal ultimately is that their O&P care be as optimal as possible, and having some of these skills to help them navigate issues that at first may not seem like they're directly connected with their O&P care can actually have a big impact. I really appreciate your time, and I think we have some time for questions, Elizabeth, if that's on the agenda.
I feel your pain. I'm sending out the link for the survey to everybody. If anybody has any questions, you can check them directly to John. He should be able to see them, and then he can just answer them out loud. We are going to be, our last class is going to start in about 25 minutes. So after we're finished here, you can take a little break and just come back and log in for that. Let me know if you don't get the survey link.
I'm looking at, so somebody mentioned, which I think I appreciate the transparency, that even if our impulse is to help, very often if somebody doesn't take the help, then the response is fairly negative. And I know what I say in the back, right, to my colleagues is probably a better reflection of what I actually think of patients than what I say to them. And it's very easy to get into a cycle where, so here's this patient again, who's coming in and they're going to be late, and there are all sorts of things on the list of things they're going to do wrong or be wrong about them. And it's really helpful, I think, to have some strategies, recognizing that we can't ultimately make them take our advice or make good decisions, but just understanding the challenges they have in doing that can put us in a little different mindset. Yeah, and I think the other part of the question was how we can keep that balance sort of being a helper. And most of us got into the field, I think, because we want to make a significant impact. It's also very personally rewarding when we do something and make something and the patient uses it right and responsibly and has a great outcome. So it can feel like a personal failure when that hasn't happened. And I think balancing the realities that I can do my best for somebody and I ultimately can't make their choices for them is helpful, but easier said than done.
Exactly. Do you want to give everybody your email address? And so if they have other questions that they
Yes,
don't
let
want
me
to.
put it into the chat. I should have,
Okay, that'd be good.
should have had that in my so it's john.brinkmann@Northwestern.
Perfect. Great. Thank you for doing that.
Yeah, no problem. Thanks a lot for the opportunity.
You're welcome. Oh, you're getting more thank yous. So I'll just
Awesome,
leave.
thank
I'll
you.
just leave that up there, and you can shut yours down when you want. I'm going to leave it open for a second so that everybody has that survey link, and I'm going to go set up Niles, and we will be back at 3:45.
All right, thanks a lot.
Thanks, John.